Good afternoon. I'm Professor Ian Hickey, Co-Director of Health and Policy at the Brain and Mind Centre, and my colleague, Associate Professor Elizabeth Scott. Welcome to the next in our series, the third, on the Brain and Mind Centre's Youth Model. How do we actually go about delivering much enhanced care for young people who present to our services with a range of mental health problems? So this afternoon's seminar really focuses on getting into the details of what comprehensive assessment really looks like within our multidimensional environment. I would like to start by paying our respects to the traditional owners of this land, where the main campus of the Brain and Mind Centre is at, which is the Camperdown, which is the Gadigal people of the Eora Nation. And their centuries of learning on those lands. And I really like the Aboriginal concepts of social and emotional well-being. What is the complete context of a person's life that leads to them being a productive member of their community and for their community to thrive? We still have much to learn from that perspective in our more Western approaches to mental health and mental ill health. Also, to recognise those who have experiences of mental ill health and their families who have contributed so much to support for our work. This is the third in the series, and it focuses on a comprehensive assessment framework. So those who've been through the first two, we're halfway. There are more to follow, moving into each area of complexity. This is the short course. This is actually just the overview. It will be followed in due course by other seminars, which actually also go into extensive case series and individual assessments, and they'll be led largely by Liz, because she's the person who takes care of people, and just how this actually looks and feels when you are actually trying to deal with a whole range of complexity in young people and provide care over a much more extended period. So today, comprehensive assessment. There are two sets of issues we want to look at in that comprehensive assessment framework. One is what we do in the classic clinical sense to drive highly personalised and measurement-based care, two of the concepts that we've outlined in the previous seminars, and that they really have two sorts of levels. One, the more extensive use of appropriate self-report. Many clinicians don't really get it about self-report. How you can get people to provide you with information in standardised ways before you ask all the same questions again and just write them down yourself, or perhaps change what the person would have said when you do write it down. And other clinical measures, which are those things which clinicians need to have skill with, but also in a standardised way that allow information to be collected in standardised ways and entered into systems over time from the patient's perspective, particularly the young person's perspective or that of their family, and also how clinicians come into that. The other is the more extensive use of objective measures. There are tests out there. There are scans out there. There's neuropsychological testing out there. There are blood tests out there. Liz, why don't people use them? Psychiatry, can I say, when I was really young, Professor Gavin Andrews, who was young and always was young and still is young, that'd be 90 years old, wanted to know why psychiatrists don't use tests to assist them. Liz?
I think we don't train them. Then it's not part of our training. I think we're responsible for that. And that's, why for the next generation of young people coming through, we hope that this does become part of standard practice for care.
A test doesn't need to be perfect. A test doesn't need to actually tell you the specifics. The test is within the context of the clinical particular situation. And again, it allows important information to be standardized and tracked over time. So a lot of what we'll talk about is where that is at in mental health, and particularly for the medical groups involved, order the ones you can and make use of them to understand more the total physiology of the person and the tracking of that over time in a highly personalised ways. And for many of our other important colleagues, particularly in the neuropsychology world, the use of other standardised tests that are there. We'll also mention the ones that can be collected more and more by personal devices. You can use objective measures of personal devices to measure activity. Liz measures every day how far I walk or don't. And you can measure other sets of issues with regards to where people are doing, what they're interacting with, their sleep-wake cycle, etc., that can feed back into everyday practice and can provide summaries over time. I personally love it when patients I look after turn up and go, look, Professor Hickey, what you prescribed didn't work. So what else are you going to do? Because here's my sleep-wake cycle, here's my actigraphy, here's my data. over the last month. Not roughly how have I been, here's the variation in that. So use of objective measures and uses of devices that provide information over time. This is the 21st century. Let's use some of the technology.
Working with me at school and then having to withdraw from school early. So working in conjunction with that, experimenting with spiritual healers, naturopaths, physios, you name it, it was all based and would go down to the fact that I was struggling mentally and I was showing all these symptoms, but we weren't sure what was wrong for so long. But actually finally getting treatment for something which was going on for me for years was with a psychiatrist that I saw for 3 years. However, it didn't go anywhere and I got to 17 years of age and that's when I met Liz and Ian.
Well, Jess fortunately met Liz. I think I met her family. And I must say in that sense, working with her family as well as with Jess about what had happened. I think interestingly with her family and with her siblings, another common criticism we run into is you don't work with the relevant social group. And I think Jess is a good example of working with her family, her brothers and sisters, and very specifically Liz over a long period of time and not being put aside. She'd more or less been put aside by another specialist clinic as being untreatable at a particular area. Got to say repeatedly in this area for young people, the notion that you're untreatable because you haven't responded to the original formulation, the original assessment, just can really miss the point. Anyway, moving on to review the model in general that we operate. Oops, we've started just talking again. We're focused in this area on the personalised assessments. And we have actually, in the previous seminar, addressed the issues of clinical staging and pathophysiological mechanisms. Here, we're talking about the more detailed clinical assessment on an ongoing basis. Now, when we introduced these concepts in the earlier seminars, we focused on the 5 dimensions that we're particularly attached to: social and occupational functioning, self-harm, suicidal thoughts and behaviours, alcohol and other substance use, physical health, and last of all, that thing we talk about endlessly in clinical psychiatry and psychology, illness, type, stage, and trajectory, the diagnostic stuff. In the context of everyone's life, Jess will be a very good example, and others, assessments in all of these domains by the appropriate clinical measures and by appropriate objective measures is just fundamentally something we need to do and track. Going to the next slide is then really putting that within the framework we were discussing earlier on of being transdiagnostic, not preoccupied with an individual diagnosis, but also in terms of clinical stage. And then assessing concurrently other areas of potential impact, social function, comorbidities like drug and alcohol, but also effects on brain development and brain change as a consequence of progression of illness. So if we move to the next slide, go back to Jess. Hopefully it'll run. Why it all matters.
As you can imagine, I've had to tell my story lots of times. It's like a broken record. Even my mum has said it many times and still does. And she will have to have said it on my behalf at times when I couldn't really speak. But yeah, I mean, look, it's evolving as I evolve. But the story that I had to tell frequently, because I had to say it so often because I wasn't getting anywhere, it became frustrating and quite like triggering, and almost sometimes even I would feel numb when I've had to say it so many times because I feel like it's just, you know, meh, like I am. Sometimes I say it with pride because I realized how long it's been. Now it's been 10 years since I first showed massive signs of chronic illness. So yeah, I think the story thing is ongoing, but back in the day when things weren't going anywhere, it felt like that's all I was saying and living. And, you know, I was just this kind of thing, you know, I was a label. I was depression before I got diagnosed with bipolar. So really, I was just this walking mental illness, and I lost my identity.
There's a lot of really profound things in what Jess is saying. You know, I'm just a label, my loss of identity. That issue about not just the redundancy of telling your story over and over and over again and bringing no records from the past with you. Everyone starts again with no reference to the past. Her notion of triggering, I think, is a really important one. And one's been raised with me several times just recently, that every time people are asked the same thing again with no reference to the past, we seem to forget how traumatic many of those experiences have been. And why don't we know? Why are we so dismissive of what's happened before, of previous interventions, failed interventions? And why is there no data? Why was no data systematically collected? Liz, do you want to comment? Because you're often inheriting many of these people who've been very complex, just like Jess, come from other systems, and yet no useful information comes with them, no real clear outline of what has happened, an unwillingness to share information.
I think it also reflects the fact that some of the information is not that helpful. What you often get are a list of medications that haven't worked, which is not necessarily an almost a sense that it's the person's fault that they haven't recovered. That, you know,
yes, you didn't get better.
You didn't get better. You shouldn't have got better. Therefore, you must be something wrong with you, or it must be a personality disorder, or
of course
there must be. So I think, in a sense, the way that we analyze, or the way we look at complex cases reflects the data that we then provide and the data that we collect. Just as a really good example of somebody who has a very complex mood disorder, which goes with the complex physiological, metabolic and hormonal comorbidities that we see with these disorders. So has changes in metabolism, a hormonal system, she's got endometriosis, a whole lot of other kind of complex issues that were really important in the management of her care and her recovery. So it does indicate how important it is to look at all aspects of a person's health to record.
You mean she hasn't got just one problem?
She does not have just one problem. She has a complex disorder.
And you mean changing the diagnosis hasn't fixed it? I mean, really, because I'm my favourite for those who saw Seminar 2. I mean, isn't the worst thing that could happen is to see a professor of psychiatry who says everyone else was wrong and just changes the diagnosis to start again?
And stops your treatment and yes.
Persists?
Yes.
Doesn't dialogue with the previous treating person?
No.
But worse, there is no record, there's no track, there's no of these dimensions. The failure of, in a sense, the classical medical thing of Occam's razor of looking for the one simplest explanation is that people's lives are not simple. And particularly teenagers, you've got physical development going on, you've got hormonal development going on, you've got social development going on, you've got brain development going on. And in many situations that we're dealing with, many aspects of the person's life are disrupted concurrently and are relevant to their whole being, not just the particular diagnostic group that we choose. But to emphasize here, what we'd like to do in the future, we don't want to just criticize everyone else, we're going to criticize ourselves for not having devoted enough attention continuously to having standardized measurement in each of these domains over time, sitting alongside personal narrative and engagement. So while Liz has been in a partnership and a journey with Jess and her family over the last decade, that's also meant having really good standardized assessments, and that she knows what is better and worse, and we can work out what is better and worse. And if there are changes in aspect of her physiology and changes to her physical health, changes in complications, more likely to develop metabolic complications as time goes on as a part of this whole multi-system inflammatory process that she has, we can actually track and respond early in the course of each of those sets of problems. So moving further into now the assessment issue. First of all, is the issue in relation to self-report and clinical measures. Just to say, there are, and what we're going to do in the next series of slides, somewhat laboriously, but a little bit slowly, is to say there are measures in each of these 5 domains. And it's our view that we should be using validated scales and questionnaires to assess those measures. So you get out standardized scores, and those scores are tracked for the individual. It's not about the group average. It's about the individual being able to move over time. So if we go to the first of these around social and occupational functioning, our favorite, there's 2. Just up the top, if you're an OECD nerd, if you really care about the higher levels of productivity, for young people across societies as a population health measure, not being in education, employment or training, NEETs, is a critical variable. And I must say, as we now face the COVID-19 challenge in Australia, the proportion of young people who will fall into this category will increase with dire circumstances, not just for themselves, but for the population at large. Participation, it's about participation in those key aspects. Now, there's a lot of people say we're a bit insensitive, focusing on being in education, employment or training. Do you want to comment on that? Is this just gross insensitivity? Are we giving into the neoliberal economists?
So if you ask young people what is most important to them consistently, they would say they want to be in school, they want to be, well, not necessarily want to be in school, but they want to be with their friends, they want to socialize, they want to continue to be on a path like their peers, they want to have a job, they want to have a social life. So it's not necessarily that they want their auditory hallucinations to be, reduced, or they want, their fatigue to be better, but they do want to be able to function. So function is the most important thing for majority of our patients, particularly for young patients. And I think it's the thing that we probably focus on the least. And in the systems that I work in, it's the thing that we have emphasized the most, that all of our treatment interventions need to be directed towards improving the young person's function in their community.
Well, one of the most important people I've ever worked with in my career, John McGrath in Melbourne, who set up the Mental Health Council of Australia and had sons with schizophrenia. He remarked one day the most important thing that ever happened to one of his sons with a very severe illness was to get a voluntary job 4 hours a week. Because he was then able to go out in the world and say, when people said, what did you do? He didn't say, I'm a person with schizophrenia at home doing nothing. He was able to say, I work for the volunteer charity he worked for. No one asked him how many hours a week he did or whether it was paid or unpaid or what the status was. He had an identity. He had a purpose. He was engaged. And the impact of that on his self-esteem, on his suicidality, on his mental state was profound. 4 hours a week. So the issue here about being in as distinct from not being in at all. And sometimes people will split this particular variable up as to whether you're fully participating in education, employment and training, or you're partially participating, or you're participating in other things. Most of this being, frankly, though, outside of the house. It can be very hard when people have home-based responsibilities for care, for childcare, for carer roles, etc., to actually be sufficiently engaged outside while they have a lot of responsibilities at home. But even so, for young people, for most young people in the 15 to 25 age range and 15 to 30 age range, this is a key personal and population level metric. And we'd encourage people to record it, the extent to which people have been or not been in participation. The standardized way to use a numerical way of doing that we use is the social and occupational functioning assessment scale, which is a global range from 0 to 100. A score above 70 is typically associated with reasonable degrees of functioning. We see a lot of people presenting to youth centres who may or may not be threshold for specific disorders who are in the range of 40 to 70, which is really very bad to not very good, to being significantly impaired. And we are tracking that over time. And one of the things when you think you're doing a great job in reducing symptoms and in other important areas like reducing suicidality is to realise you've gone nowhere in terms of functioning. And do you need to think about who's engaged, what it is, and what is the highest priority for the particular young person and their family in sort of putting them in their role. There are other well-standardised scales. We'll just emphasise two. The World Health Organization Disability Adjusted Scale, known as the HUDAS, a 36-item generic scale that assesses these areas. It's also the Work and Social Adjustment Scale, which is a 5-item scale for functional impairment due to any particular problem. Another one is the Social Relationships and Support Scale, which puts the emphasis on social support. So it isn't all just about economics and training. It is, of course, the extent to which people have a social kin. And of course, the experience of mental health problems, particularly as a teenager, is likely to result in actually having less social support. So while we rabbit on about the NEETs business, of course, the other thing that most of us want is people that care about us and to be embedded. And for teenagers, actually having social support, friends, relatives, etc., is obviously critical. Another particular instrument that we do use to some degree, the Brief Disability Questionnaire, which simply records the number of days in the last month that you were out of role, didn't go to school, didn't go to work, didn't go to training, and the number of days that you were in bed in the last month. So even if it goes down to numerical, simple reporting of those over the last 30 days, keeping some kind of standardized measure throughout that period critical. And just ask yourself every while, have you made progress? Go to the next slide. Right. One of the most common reasons that young people come into care has to do with self-harm. They have self-harm, they've attempted suicide, or they are expressing suicidal thoughts and behaviours. It is the panic button. It's the one that causes parents, families, teachers, and the young person themselves to often seek care. Now, this is often recorded very poorly, or just said not. Person not suicidal, not whatever, actually it's distinct from taking a more dimensional approach to that. And the SIDAS, the Suicidal Ideation Attribute Scale, is the one that we use. It's a simple 5-item self-report questionnaire looking at these particular sets of issues. There are other more elaborate questionnaires that are commonly used, the Columbia Suicide Severity Rating Scale, and down the bottom, the Brief Non-Suicidal Self-Injury Assessment tool. Of course, people worry. And I've had a bit of this myself this week in national media. If we talk about it, we'll make them do it. If we show them a questionnaire, they're suddenly going to have these thoughts they never had, or we're going to make it worse. Liz, has it ever been your experience that talking about the problem made the problem worse?
No, certainly not in a professional environment. In fact, the opposite is true. We really don't ask enough. Often we make assumptions, we don't necessarily ask, and then people either feel we're not interested, we don't want to know, or there are other kind of reasons why they're not discussing that. So I think the general, consensus is we need to ask more, and we need to ask in more standardized ways so people get better at reporting how they feel and their level of risk.
In a lot of clinicians, where I just really don't get it in the sort of reluctance about this, you go to another level. If I ask and they find they've got it, then I'm going to have to do something. And unfortunately, for some people, the do means immediately hospitalisation, ambulances, others. And in fact, in the world of people experiencing these problems, particularly with young people, they may well be afraid of that as well. But disclosure being encouraged and being contained within and then being tracked in the rating systems that are now using this with smarter technology and tracking over time, what you do find out, whether you wanted to know or not, is that suicidality and suicidal thoughts are very common and persisting, but they vary in severity. And knowing that and recording that leads to much more active care planning and safety planning and how to deal with those particular impulses, actions, moods, or contexts that may exist. My great friend Neil Cole, who has bipolar disorder and writes about this, he said, when the fog of suicidality descends, you need to know that, you need to be aware of it, the clinician needs to be aware of it, you need to know that it will lift and there will be another day. But when you're in it, you need to have a plan, you need to have an action, it needs to be thought about. If it just descends on you, you just get lost. And I think, it's one of those areas of clinical practice at the individual level and at the clinic level, we've got to lift our game, track and respond more quickly and more sensitively to the needs that people have and focus on specific interventions to deal with the context, the self-harm, the impulse, the mood, the risk in appropriate ways, and involve and engage others in that. The next slide. Okay, well, every Australian, of course, doesn't drink as much as they say they drink, and the recording of alcohol use, what people think they're drinking, as distinct from when they start recording their drinking, and also recording other people's response to their drinking. Does a friend or a family member think you have a problem with alcohol? Have they noticed? Do they think you should seek medical care? It becomes important to actually do this on an ongoing basis. So we use the simple identification test, the audit or alcohol use disorder identification test, simple 10-item transcultural screening. Works pretty much all over the world. You just get people to actually talk about the nature of the problems that they have. And again, in that environment, to bring to our attention, but often for all the questionnaires, for all the stuff, for the person themselves to be able to come to a realization of a context of a particular issue, particularly if they have been skating over the issue, that their current pattern of use is high or their current pattern of use has changed in relation to their particular situation. And again, often something that we downrate that families, young persons themselves know is a significant problem with significant longer term impacts. Again, the asking about to guide what happens next. Next slide. Physical health. Now, for the medical members of the audience, you are medical practitioners, you are physicians. Liz, how much of your time is spent sorting out the medical problems that have not been well documented, tracked, responded to in young people, because of course they're physically healthy. They all look like Jess, they all look like Sam, they all look like people. They haven't got any physical health problems. And we're mental health practitioners. How much of your time is devoted to trying to get this straight?
So I would say a large proportion of my time is dealing with the key medical comorbidities that we see associated with the young people who present to our care. And they are around metabolic health, they're around immune and inflammatory conditions, and around hormonal conditions. And those are the kind of commonest comorbidities that we see. And I think as practitioners, we need to develop the appropriate assessment skills and have some idea about then what kind of interventions, not that we necessarily provide them ourselves, but how to refer people on, and what are the types of interventions that young people need to maintain their physical health and improve their physical health outcomes over time, that are also really important to their mental health outcomes.
So to get really blunt here, if we run things in which we do not know people's height, weight, and waist circumference to calculate their basic BMI, we've failed. If we aren't using some tracking device for their physical activity, since physical activity drives their mood, their cognition, their sleep-wake cycle, as well as reducing their risk factors. And in the modern age, just some really, I don't know, guess, I suppose I went for a walk yesterday or not, doesn't cut it. You've got to use the machines. You have to, somewhere we'll use activity trackers, whether they're Fitbits, whether they're smartwatches, whether whatever. Our population has to be active. People say, I'm very active. 2,000 steps a day. That's not very active for a teenager. In fact, it's some work we did earlier on. We found that young people with depression actually moved less than older people with depression. A lot of screen time, a lot of bedtime, a lot of social withdrawal, a lot of oversleeping. Really bad in terms of particular factors, which can be tracked and can be looked at. And of course, the more information people have, the more likely they are to take an action. If they can increase, even if they're incredibly unwell, if they can increase their step from 2,000 steps a day to 2,500 steps a day, or to 3,000 steps a day. You know, these are very significant changes over time where people can become active in these areas. Some of you may know, and some people around here know, I'm the son of a cardiologist. The thing that drives me most nuts in the physical health area, when people go on and on and on about all sorts of things, is not asking whether people smoke. And then if they do smoke, what actions are we taking to try and reduce or quit smoking, which is the fastest way to save lives in this area at all ages, is to reduce and preferably quit smoking along the way. And for that to be clear, it may not be something that can be always done immediately. It may be really challenging. It may be difficult. Many of the people we have seen who are older will have tried many times before, but of course, when people are younger, the chance that we can actually influence that behavior is large. But sad to say, in our populations, the rate of smoking is 2 or 3 times higher than the age-adjusted other factors. And of course, we also see other sequelae of that, and particularly the reverse sort of pathway idea that people go from tobacco smoking to cannabis smoking into other at-risk health behaviours in particular ways. In the physical health area, Liz, in terms of the metabolic screening, you've really led the preoccupation we have, not with simply fasting glucose, but with insulin and actually the detection of insulin resistance before people get fat. People like me eat too much, takes 60 years, later on their metabolism's gone off. In a lot of young people, we see insulin resistance before they get fat. There's something going on inflammatory wise before they get unwell. So just tell us about your approach to that.
So we've taken the approach that we screen all young people presenting to care, whether that's within the Headspace clinics or within our tertiary referral kind of hospital system, that we screen everybody for their metabolic status on entry into care, because you cannot rely on BMI, you cannot rely on other factors like medication to show you who is at risk. So we do screening, and we do look for insulin levels, including in addition to blood glucose and lipids, and find much higher rates of insulin resistance in the young people that we see presenting for care. That means that we need to make sure that we have that information available to the wider clinical team in terms of treatment choice, but also in terms of identifying those people who we need to do more assertive interventions in terms of physical activity. And like Weight Watchers, often interventions for physical activity work better if there is coaching and accountability. Groups.
Peer encouragement.
And peer encouragement.
Do the watch together. Get out there as groups. Engage others. It's very easy. It's hard to tell people to lose weight, be active more. This is hopeless. It's got to be part of a group, often involvement of families here, to achieve change over time. And when you get the insulin and the glucose, you can actually calculate something called the HOMA2, which has got to do with actually the standardized measure of adjustment of insulin resistance for glucose to work out what is actually happening, the homeostatic metabolic systems, which we provide references to, and we are studying in great detail to track. Guess what? We want to prevent people becoming insulin resistant, not wait until they're overweight 30 years later with premature cardiovascular disease and tell them they should have never got here. Liz, you've also spent a great deal of time in the autoimmune area in terms of standardized assessment there. You just want to comment, because this is such an interesting area now, in what sorts of people we do go into more detailed assessment, not just at the simple inflammatory markers like CRP and ESR, but into more detailed assessment of autoantibodies and other systems.
So this has partly become a worldwide interest in this kind of notion of inflamed depression or inflammatory depression, particularly taken up by the English, who believe that they can now develop a monoclonal antibody to treat depression, which I think is a really interesting concept. But we do spend some time trying to identify those young people who we think might fall into that group, and they are the group who have more fatigue or sleep-wake cycle disturbance, have more somatic symptoms. They're also young people who have a more family history of immune dysregulation or immune disturbance. And there are also those with more atypical symptoms who don't necessarily respond to the standard treatments, SSRIs or CBT. In those young people where we think that their symptoms are severe, atypical, and there is a family history, or we do find immune markers, we do more extensive immune testing, and a very small proportion of those people end up with the types of complex immune disorders that really need more thorough assessment and intervention, and often sometimes go on to kind of immune interventions to treat their symptoms. So this is a really expanding area. I think it's really interesting. It will tell us much more about the pathophysiology of the syndromes that we see, and it will require us to have new sets of skills.
Just going back to some slightly older things, just go back to the endocrine area for a moment. I can't tell the real truth here, but let's just say more than 30 years ago, Elizabeth and I published a paper with others at the Mood Disorders Unit, which became the Black Dog Institute, on thyroid function in treatment-resistant depression. And we used to have a lot of debate at the time about so-called subclinical thyroidism, meaning the endocrinologist didn't really want to treat somebody who had a raised TSH and abnormal thyroid function because there was nothing wrong with them. He said, excuse me, they've got a treatment-resistant depression. There is something wrong with them. They've actually got a particular issue. And I think in the treatment-resistant literature in that area, there's always been a lot of interest in thyroid function and whether thyroid hormone treatment may be required, but there's nothing subclinical about it. People are actually very unwell, and in the populations we look at, raised TSHs and thyroid abnormalities, whether they're autoimmune driven or they've been driven by other factors, is quite an important issue, particularly in young women, and particularly as you go on in life in particular ways. As some of the distribution of a number of the endocrine, autoimmune, and thyroid disorders are more common in women than men. And in other areas, so in that area, I think remains one where I often say, you ever had your thyroid checked? No, because I'm young. I mean, you find raised TSH or you find thyroid, or, the actually person already has other evidence taking place. The other one in that particular area, Liz, you've been involved in a lot, is in the polycystic ovaries area. I just want to comment briefly about that.
Yeah, so both PCOS and endometriosis are overrepresented in the populations, the patient populations that we see. Obviously young women who present with mood disorders. And that's true if you look at the endocrine clinics, those clinics that treat PCOS or endometriosis, there are much higher rates of depression, and vice versa in our psychiatry clinics. So developing some standard questions for the hormonal system, and then being able to provide there are some now well-documented assessment tests, blood tests for PCOS and ultrasound tests, and there are some standardized interventions, so referral pathways and interventions for those young people who test positive for those. And that becomes an important information in terms of understanding the complex pathophysiology that young people have in terms of their mood disorders, but also how to treat them better and how to prevent some of the longer term consequences of those disorders like infertility.
Another area, of course, remains really complicated, the use of estrogen therapies and of selective estrogen receptor modulators, SERMs in these areas, complex ongoing areas. but ones that are often very relevant to a number of young women, those who've been highly androgenized, where there are particular issues, or those who particularly in association with their cycling have very severe changes in their mood disturbance. Complex areas, but if we aren't talking about it, if we aren't measuring it, we're not really responding to the challenge we face. Next slide, please. Okay, so what, specialists love, what illness have they really got? What's happening over time? And as a patient of mine said, she has more labels than a jam jar factory of, and the label just isn't hers, as Jess was just saying earlier on. Of course, it is important to try and collect standardized information in these particular areas about the lifetime history. We particularly, as discussed in the last seminar, have a focus on actually clinical staging. And that's a really important concept to actually track over time. There are other important aspects we really do need to know. The medical ones we've just been discussing, family history, which remains an important predictor, and again, of response to treatment, where people have been, and the relevant syndromes. And the syndromes that can be well collected in various questionnaires and standardized for their symptom sets can be useful. Next slide. Now we'll see if we can get Kathy's story to run about her daughters.
Lost a piece of ourselves. Given the lack of time dedicated to an appointment, you had to frame your story depending on what specialist you were seeing. I would say to my daughter, the endocrinologist doesn't want to know about that. The neurologist doesn't want to know about that. The immunologist doesn't want to know about that. It was only when we found the best psychiatrist at the BMC that they wanted to know everything, and they created a therapeutic environment and relationship with a team that worked together and combined physical and mental health that we finally began to make progress and continue to do so. As the years have gone by, the length of our story has become rather long. I dread to think if we now had to change clinicians and have to start all over again. It would be rather exhausting. Retelling your story also brings up the traumas experienced over that time and results in lots of lost energy. The impact of the illness on the whole family is lost at the time, and it is not until your person gets a little better do the cracks start to appear in the rest of the family. Siblings can suffer to a point of irreparable trauma. It is important to include them in the treatment. Relationships with the wider community for the family also suffer.
So Kathy's raised a whole lot of issues there, which are incredibly important. Just to pick up a few, it's great that in the time that they have come under Liz's care and the wider Brain and Mind Centre, that we've been able to track data. Now, should it be the case that ever Liz drops off the perch or the BMC closes down, hopefully what we would have is actually the collected history over the last decade to transfer to any other treating agency so that it's not lost and doesn't all start again. There's clarity, there's documentation, there's laboratory tests, there's a clear articulation. The other issue is that one, I've seen all those physicians, but until they saw a psychiatrist, no one wanted to put all of it together. A very famous Australian psychiatrist who's recently died, Barney Carroll, went from Melbourne to set up the dexamethasone suppression test in the UK and in the United States in the 1980s. Once in talking to people asked him, "What are you?" He said, "I'm a physician and I specialize in mental health and psychiatry." And if ever challenged about it, he made that extremely clear. And while part of a wider multidisciplinary team with clinical psychologists, mental health nurses, general practitioners, when describing the fundamentals, he made the point, and I think it remains true to this day, fundamentally, unless we approach this as physicians, we're likely to leave out critical aspects and to assume in the age of super specialization in medicine, in psychology, in every other discipline, that anyone cares about the totality is a wrong assumption. So I think there is a really critical issue here. While we ourselves are talking about various dimensions here, we're trying to hold together the whole of that of the physician who is interested in all those aspects and interested, of course, in the interrelationship between those sets of aspects over time, a critical set of understandings. So on to the next slide, if we can. Right. We can't always see what we can't see. I don't know if you've ever tried to guess a TSH or ever tried to guess the fasting blood glucose or ever tried to guess particular things. Some of the thinnest people I know don't have the lowest glucose in the world. Some of the people I know don't have the lowest cholesterol in the world. Others, where you think you know what you know, you don't know, and neither do they. I've just recently had a friend remark after I've been involved in her care. Her husband said to me, Ian, I didn't realize you were a doctor. And that real interest you took in her brain scans, you could actually read those brain scans. I thought you were just a, psychologically minded person, that you actually had skills in those areas. And I said to him, Michael, it's not that. It's that all of my other colleagues should be ordering those things all the time and tracking them over time, whether it's the brain scan, whether it's the blood test, whether it's the neuropsychological test. Those objective measures tell us things about the person that we don't know. We will shortly be in the age, I think, of polygenic risk scores, which will be probability estimates based on whole genomes, sequences of a person, not individual candidate genes, that will also tell us additional information. As Gavin Andrews said 40 more years ago, why don't we do it? And if it was helpful. And then in fact, other physicians use those all the time. We focus on objective measures in a number of particular domains: neurophysiological function, neuropsychological function, sleep-wake cycle and circadian rhythms, metabolic immune markers, which Liz and I have just been discussing at some length, and brain structure and function. So we go to the next slide. In the neuropsychological area, there are standardized assessments, and increasingly many of these are online. They're easily done. They don't require 6 hours of standard neuropsychological assessment and just about that many dollars as well, hundreds of dollars, thousands of dollars of time to get it done. They can be done repeatedly and do the same thing over time, tracking basic functions around attention, speed, memory, particularly executive function and cognition, and standardized. In all of the studies that we do, the strongest correlation is between neuropsychological function and impairment. Those who've grown up with difficulties or those who develop difficulties in function. And of course, to everyday life, we depend on those things. If you can't concentrate, if you can't work out, if you can't remember as a consequence of the mental health problems you have, you cannot function. Now, when we detect abnormalities, there is, of course, the issue then of more extensive functioning, more extensive assessment by skilled professionals, or more extensive testing in those areas, where more detailed testing may provide more detail. Very important set of areas. Liz, why don't we do it? Why don't mental health clinics have neuropsychological function built in? And you want to tell the story of introducing this to St Vincent's Hospital?
So we have in our inpatient unit introduced a brief screening neuropsychometric assessment, which is iPad based, which takes about 20 minutes in total, and is well received by the young people in the unit. It has been extremely difficult to get it into standard practice. And that is for a number of reasons that people don't. Things that get into practice are things that you use in decision making. And it has been very difficult to make the link between the testing and bringing that into the clinical decision-making, real-time process.
Yeah. Got to go back in real time. Okay, so that's one we'd like to see progress. And again, the technology is going to save us from our own bad behavior. Sleep-wake cycles and rhythms, all you need really is the watch. The actigraphy watch, and a very expensive one or a less expensive one or whatever you've got, that feeds back and shows the activity, not just the sleep period, the 24-hour period, and builds that over weeks and can tell you whether you've been very active or you haven't been active, whatever way you particularly want to do it. If you want to even show, today I've done nothing because I've been sitting here at this Zoom screen all day. But I haven't been such a bad guy all week. I've done some other activities and I think, oh my God, if I don't do something today, I'm not going to do something. And actually, for weight gain, for activity, for other things, making things a daily activity or daily recording so that people can change their behavior the next day is critical. And a lot of the work we've looked at, that's the failure of much behavioral change in behavioral medicine, is feedback from objective data to affect that behavior. When we move in the more detailed area, there are overnight sleep studies. There are other sets of evidence, particularly we're interested in how you record melatonin and cortisol to see where the body clock actually is. Is this a person's circadian rhythm out of place? And core body temperature. They require more sophisticated experimental laboratories. I do think we will see in the near future, many of that move into the home environment with the appropriate assessments, as it's affected by light environments when you do the tests. We have just discussed earlier a fair amount about the metabolic and immune markers in addition to the measurement, just drawing attention to the ones we made a fuss about there in terms of thyroid function, C-reactive protein, fasting blood glucose, and insulin resistance. In our view, all of those should be standard practice. This is a high-risk population who has an increased risk, well documented. Personally, I have been working with the Heart Foundation now for more than 25 years, and I get asked all the time, why don't the psychiatrists do it? Why don't they know that people are going to die early from cardiovascular disease? I said they do know, but they just haven't quite got around to fixing it. In the more complicated issues, as Liz alluded to, the issues of autoantibody screening, of more inflammatory markers, and more specific new tests will arise in that area over time. Last but not least, we have brains. And you know what? We can now look at those brains. The preferred mechanism is MRI. If somebody orders another CT scan for no good reason in one of your public hospitals, could you please ask them why? Because MRI is extremely sensitive, you track over time, you can calculate volumes, there will be more that happens in this particular area to actually track changes over time. We see this in MS, we see it in other areas, we see it in dementia now. It won't just be whether radiologists can see something or not, it'll be the tracking and volumetrics over time, which is critical. And a significant proportion of the young people that we see in the 5 to 10% range have other abnormalities that are detected that may or may not be related, but they're important. And we will see in the further assessment here, both in other aspects of MRI development, looking at white matter tracks, and also in magnetic resonance spectroscopy, MRS, looking more locally over time, other factors. But get on the path early. Get on the path early. Start to track in young people what you can be done. MRI, simple structural MRI, should be the standard in this area. Speak to your hospital now and others and track it with time. In association with neuropsychological testing and other factors, this has often added greatly to our own particular work. With the next slide.
Simply put, we get the care and support we truly need when we need it, without the hassle.
What a great bloke Sam is. You know, actually, complex, difficult set of situations, Sam doesn't mind me saying, on to have had unexpected medical complications, which may or may not be directly related, but knowing what his medical status was, being able to act in particular things, seeing the relationship between his physical health and his mental health has been critical and remains central to our physician-based approach to detailed assessment. Next slide. Okay, we aren't all the way there yet. There are two limitations. How the hell do you track all this together? Well, we suggest one of the ways, if you haven't got the technology, you're going to need to get the technology. If the service you are in doesn't have something like the InterWell platform or a standardized system, it's very hard to bring this back into real-time practice, to share with a person during the consultation where they've gone, where their tests are at, through the dashboard type mechanisms that were there. And led by our great research director, Tracy Davenport, this kind of work is out there being tested all the time. And new tests and the utility of new tests is something that's being tested all the time. We need to make sure that we combine the patients that we are seeing and the families that we're seeing with those particular issues. And so having a data system that makes it live and is live in your room, like many people are doing now with telehealth, alongside the Skype screen, where's the dashboard to say where the person's at? Where's the data that actually comes in on an ongoing basis? A lot will change in our lifetimes, and it's changing quite rapidly. The challenge is, will we use it? As Gavin asked 40 years ago, it was there then. It's there now in spades. Are we going to make use of it? Next slide. So in summary, we think there are a range of self-report clinical and objective measures which should come into standard practice. Make more use of self-report. Don't ask the same questions over and over again that people could have just provided before you started. Don't waste your time and their time. Track it over time. See the changes over time. That will actually help move towards highly personalised and measurement-based care. Be prepared to actually look at what else needs to be done. And further investigation actually leads to actually finding people who actually have particular phenotypes and particular categories, some of which are being worked out: immune-related depression, autoimmune, endocrine, certain neurodevelopmental kind of conditions, better characterization of the atypical depressive disorders, all going to help in those particular areas. And ideally, As we'll discuss next time, please come back to the next seminar, because having found all the information, the next thing is what do you do about it? How you actually take it into standard practice. We don't just do this assessment and track it to amuse ourselves or publish, although Liz has published many excellent articles on these issues in these large cohorts on particularly the metabolic and physical health complications along with our clinical staging and its outcome. But our point is we're trying to treat people better, give them the best options. So the next seminar on Tuesday, the 19th of May, will be actually best care first time, having undertaken this set of assessments. So we hope to see you again at that occasion. You can access these actual web-based treatment systems through each of the seminars, and you'll see each one as we do them progressively will be uploaded to YouTube so you can watch and share, or remind yourselves of what was said, or access the materials. And the references associated with this work are particularly outlined well in the Medical Journal of Australia supplement from last year. And if you contact us, you get a freebie. We'll provide it to you, and other resources we can direct you to, including the Cambridge University book on clinical staging and the German forum on youth mental health led by Stephen Wood and his colleagues. We are also keen to make available to you. So that brings us to the end today. This work would not be possible without the support of Future Generation Global. They're investment bankers who want to see young people have a better life and donate their services and their money to support this work, without the support of the families who've actually also invested in this work, and of course without the support of our colleagues through the Headspace networks, and particularly those who are associated with the Brain and Mind Centre. So we thank you for your participation, and we hope to see you again next time.